Welcome back, Rebel EM listeners, to another episode of Rebel Crit. I'm your host, Frank Lodeserto, and I'm joined by my co-host,
Dr. Eric Acker.
Eric, we have a very exciting topic today. We're bringing in a guest speaker and one of our own pulmonary critical care fellows. Who is it, Eric?
So we have Dr. Alex Chapa, like Dr. Lodeserto said, second-year Pulm Crit fellow, but he spent many years as our nighttime intensivist consult service.
Yes, Alex is one of our pulmonary critical care fellows, good friend of mine, and we're going to tackle a interesting paper that Dr. Chapa recently published, and it is great. It's a short paper giving an overview of corticosteroids in bacterial pneumonia, and I know we've talked about the Cape Cod Trial. We'll talk a little bit about that, but we're just going to give you more background and maybe some future perspectives on corticosteroids in pneumonia. But without further ado, Alex, tell us a little bit about yourself.
Thanks a lot. Happy to be here. Like you said, I'm a second year or a fifth year fellow. I think this was a labor of love as far as I'm concerned. I found there was a lot of discrepancy in the practices of using steroids for pneumonia. I found that this trial, Cape Cod, was the one that split the difference between the people that were hesitant about using steroids and finally provided some arguments of why perhaps we should be doing it.
Well, Alex, let's get started with some context. I'll throw some questions out. Give us a quick historical overview of corticosteroids in pneumonia. What did the early trials and guidelines suggest, and why is there this long-standing skepticism? And then, as you mentioned, the Cape Cod Trial probably put everyone over the top with the use of corticosteroids.
Well, steroids initially were entering practice in the 1940s and 50s as a way to manage inflammation due to autoimmune diseases. Already there was a hesitation about secondary superinfections and things of that nature. Between the 50s and the 70s, some data started to percolate as far as using steroids for severe PJP. 80s and 90s, you start to see some small studies for severe pneumonia and ARDS. Now, where it gets interesting, which is where our paper picks it up, is from the early 2000s forward, where you start getting RCTs and meta-analysis specifically looking at community-acquired pneumonia and either preventing progression to ventilator support, ARDS, or other comorbidities. They start to try to define severe pneumonia with different criteria, and sometimes they would use CRP. Unfortunately, from about mid-2010s forward, there's different levels of CRP that were used. And consequently, the data has been spread throughout an awful lot of possibilities where you can cherry pick a paper that says yay or nay on this issue. So in the middle of all of this, we have what the guidelines would say by that time. So 2007, the American Thoracic Society and the IDSA just did not address the topic at all. They felt there was not enough data. By 2019, so there's a big hiatus there, they recommended against using corticosteroids in severe community-acquired pneumonia, which is interesting because this is pre-COVID. And they did acknowledge there was no benefit for non-severe pneumonia, but the data was just so spread as far as the benefit for severe pneumonia that they could not at that time endorse it. So in the middle of this milieu of options, the Cape Cod Trial starts. They acknowledged those controversies and standardized, at least in their protocol, what they defined as severe pneumonia. I think they did a pretty good job at doing that.
So just leading up to the Cape Cod Trial, which was New England Journal of Medicine 2023, we didn't know really what to do with steroids. We knew don't give steroids for non-severe pneumonia, but it was a little gray area of what to do in severe pneumonia. Many studies done. Nothing showed a mortality difference up to that point. Maybe some secondary outcome differences, but nothing overwhelming to push us towards using corticosteroids. And even how do we define severe pneumonia? That was also not well understood at that point. Then, as you mentioned, the Cape Cod Trial came out, New England Journal of Medicine 2023, that really reignited this discussion. Can you summarize the findings of that trial and why it was a landmark of a trial?
This is a beautiful paper, and I feel like it's a landmark paper. It should be read by everybody that deals with patients hospitalized with pneumonia. As a short summary, it was a beautifully designed, double-blind, randomized controlled trial, and they were looking at superiority, not non-inferiority. They randomized both groups 1-to-1. Initially, they intended to have 1,200 patients. They ended up settling with 800 because COVID got in the way, and at that time, they halted recruitment and decided to adapt the trial to look at the benefit of steroids in severe pneumonia due to COVID. So when they picked up the trial again, they ended up doing their analysis on those initial 800 patients that were screened and randomized pretty evenly across the board. And what I liked about it is that they specified exactly the intervention, hydrocortisone as a continuous infusion, 200 milligrams over 4 days. Depending on the clinical response on day 4, they would decide to continue or start to taper. The placebo was given exactly the same way as an infusion, so the investigators were blinded. And the way they defined severe pneumonia, in my estimation, was fascinating. They obviously went with a pneumonia severity index of 130, which seems reasonable. They also looked at whether or not the PaO₂ by FiO₂ ratio was less than 300, which seems reasonable, or if the patient was started on mechanical ventilation or non-invasive ventilation with at least a PEEP of 5. And they also looked at whether or not the patient was in need of high FiO₂, either more than 50% via non-rebreather mask or heated high flow.
So what were the, Alex, in that Cape Cod trial? Just give our listeners who maybe have not heard or listened to that Cape Cod trial, what were the outcomes of that trial? What did it show? What did it demonstrate?
So they had a number of different things they were looking at. But what I like as far as their primary outcome is that they looked at death for any cause at 28 days. There was a huge list of secondary outcomes, and listeners are welcome to review the paper on that. I'll just summarize a couple. When you looked at both groups by day 28, they noted that 25 out of the 400 patients in the hydrocortisone group had died versus 47 in the placebo group. So that was a difference of 6.2 versus 11.9%, or an absolute difference of 5.6. Their p-value there was 0.006. As far as secondary outcomes, 90-day mortality was still lower in the hydrocortisone. Small difference on an absolute number, 9.3 versus 14.7%, but still significant. Endotracheal intubations were 18 on the hydrocortisone group versus almost 30% on the placebo. Non-invasive ventilation was also lower. Incidence of vasopressors was also lower. Interesting is their number needed to treat was something around 17. So one of the criticisms has been that the benefit is not as dramatic as perhaps the hype in the community led you to believe. But when you consider the number of hospitalizations and deaths for pneumonia, I think that remains to be seen. What will be the impact when this is fully incorporated into clinical practice across the board?
The Cape Cod trial, I mean, it wasn't a perfect trial. It did change some of the guidelines. What are the current ATS, IDSA, and European recommendations? What are they recommending? Are clinicians starting to use steroids more now because of these recommendations? What have you seen?
ATSA and IDSA have not tackled that topic yet. Cape Cod was published in March 2023. The earliest course correction from a society was in 24 by the Society of Critical Care. Their expert panel, based on that trial, as well as 18 others, felt strong enough to say that corticosteroids do reduce mortality. They recommended their use for severe community-acquired pneumonia, and they felt that the benefit was not only reducing mortality, but also the need for mechanical ventilation. They felt that length of stay and some other metrics were not so clear. And obviously, no recommendation was made for non-severe community-acquired pneumonia. Now, this year, in Lancet Respiratory, we had a meta-analysis done by Smith and collaborators, and they did find that 30-day mortality was certainly still there. The kicker was their CRP was 204 as opposed to 150 in the Cape Cod trial. And then even more recently to that, the European Respiratory Society has published a rather extensive document on this matter, and they've given at least a recommendation to use it for severe pneumonia, but they still acknowledge that one should be cautious of the side effects of steroids, as well as feel that there's need for more data before they can fully embrace it.
So based on the Cape Cod trial, SCCM has changed their recommendations. They took many other trials and did a meta-analysis. It looked like when they did this large meta-analysis, taking into account the Cape Cod trial, there was a lot more evidence and data to support the use of corticosteroids in severe community-acquired pneumonia. Is that right as a little summary?
That's actually 100% right.
Okay. All right. Great. Why do you think they used, because we have all these steroids out there, right? We use hydrocortisone in shock. We use dexamethasone in ARDS or dexamethasone in COVID. Why do you think that they used hydrocortisone here? What are the recommendations now for which steroid to use? Because it gets a little confusing.
We're certainly spoiled for choice in that regard. Some clinicians will ask, well, why not just put them on prednisone? And I've seen that perhaps be a way in which some providers have taken the lessons from Cape Cod as a blanket statement to say you can use any steroid. When you look at the data over the last 20 years, I feel that the hydrocortisone studies showed the better mortality benefit. We still don't know why specific. Some people posit that it's mineralocorticoid activity, some way, somehow. It's more beneficial in severe patients because it supports hemodynamics. Certainly, as you allude, there's more powerful steroids. I think the data is just not that granular to parcel that out. It seems as it stands right now that it's the most physiologic and the benefits from its mineralocorticoid activity are being posited as a probable cause, but I don't have a straight answer, honestly.
Yeah, I didn't think so. So it looks though the best data right now, if we're dealing with severe community-acquired pneumonia, would be hydrocortisone. And as you mentioned, just to summarize that, it was given as a continuous infusion. Of course, many hospitals don't use it as a continuous infusion. So we're using it very similar to what we use in shock dose steroids, which is 100 Q8.
So I think what we have on our paper described was 200 a day. It can be given in divided doses, whether you do 50 every 6 hours or 100 twice a day. At this point, it seems to be irrelevant.
So the clinician has the discretion to taper this after day 4 or day 8 and maybe taper over 14 days. That's where people get a little bit confused. When to taper, how long to taper for, what are the current recommendations that you saw out there?
If we go straight by Cape Cod Trial, the way they did it was start the steroid, they get a bolus of 200 milligrams and then start the infusion at 10 milligrams an hour for at least 4 days, after which they would decide clinically is the patient's improving, can I afford to start tapering the steroids or not? As far as how we can approach that, I feel that's the best evidence we have right now. If your patient seems to be improving, you can feel comfortable that in a large trial they were able to taper without any adverse events. If on the other end, your patient by day 4 is still looking sick, then perhaps you should continue it. Perhaps this dovetails to future research questions that need to be addressed, which is how much immunomodulation do we need or when is it safe to start tapering?
And I think the key I heard you say is that we have to start it early. If we make the decision that the patient has severe community-acquired pneumonia, the key is starting this early to decrease this inflammation in the lungs. So that's key. The patients don't need to be in the ICU as well, right? We're dealing with severe community-acquired pneumonia, depending on your hospital. Some of these patients may be on the floor, less likely, maybe in a step-down unit. But as long as they meet that criteria, regardless of the location of the patient, could be in the ED still, starting these steroids if they meet this criteria.
If I could jump in, steroids being used in the Cape Cod trial, what's some adverse effects or some exclusion criteria that the Cape Cod trial took into account to exclude patients from receiving steroids?
Well, so as far as adverse events, Cape Cod did tackle the misconception that we had for many years that steroids were associated with either increase in secondary infections or GI bleed. Early, mid last century, we were afraid of that in the 40s and the 50s. When it's been looked upon rigorously, it just does not pop up. That being said, we can be good stewards. For instance, I have a discipline of when I have a patient on steroids, whether it is for severe pneumonia or interstitial lung disease, I always start my physical exam by checking their mouth for thrush. So that doesn't mean we're not looking, but at least the data right now doesn't support that we should be overly cautious or concerned. The biggest risk was hyperglycemia. The rate of hyperglycemia was rated between 6 and 12%. We practice in a state where BMIs are a little more generously proportioned, yes, robust, voluptuous. And perhaps for us, hyperglycemia is a bigger concern. So even though you could have options for other steroids, perhaps we could not tolerate the hyperglycemia side effect with a more powerful one. So for now, hydrocortisone, I think it's the way to go. However, and this is as a sideline, there's other side effects, just to honor your question, that are not addressed by the trial. So for instance, mood changes, delirium, insomnia, confusion or agitation in the elderly have not been properly addressed. They're not as glamorous side effects perhaps as the other ones, and I don't think they've received as much attention. No, GI bleed and secondary infections, as much as we have this concern, like we said earlier in the show.
So we got the steroid dosing. We know to start it early. What's your best advice for an emergency medicine doctor who's seeing one of these patients come in, or if they're on the floors, or even in the ICU? What should we be using to define severity? Are we using the PSI as our quick cutoff for severity? Would that be the best tool for somebody to make it simple?
So I think that's one way to do it, certainly. For those that will choose to check a CRP greater than 204, would certainly put you in the severe category, with the caveat that remains to be parceled out. Where is that line of moderate and severe really laying at?
And so if we are getting a CRP, and not everyone gets a CRP.
Correct.
And a lot of these meta-analysis, a lot of the studies didn't have a CRP. So they included patients who did have a CRP. Some used 150, but what you saw when you researched it is that magic number of 204 being the cutoff where we saw a benefit. If it was greater than 204, these patients had more severe inflammation and would benefit most.
Yeah, and perhaps a way to look at it is if you feel that you're in the fence and your patients say 50% of FiO₂, they're on heated high flow, high FiO₂ need, they have dense infiltrates, their blood pressure is quote unquote soft, but they're not in shock. This starts to look like the kind of patient that is quote unquote sick. So then once you have that mental image, if it met any of the criteria from the Cape Cod trial, or you check a CRP and your levels are over 100, 150, and the clinical course is marked by progression or worsening, I don't think you would be faulted if you start steroids. Patients don't read the studies or the textbook. So it is important to also keep our clinical judgment. Some of the patients included in the trial were included as severe pneumonia with an FiO₂ more than 50%. Those patients, like you rightly said, could very well be sitting on a medical ward or in a step-down unit. Not necessarily all of them are going to be captured in an ICU. In absence of that, certainly the PSI index would serve well.
So the PSI is probably our best validated tool for mortality, but it is probably the most cumbersome.
Yes.
Yeah. So other studies have used Curb 65, Smart Cop. Is any of the evidence look at those things? Can we use some of the other ones just to make it simple for clinicians?
So I think if we step out of the Cape Cod trial and get into the paper that my colleagues and I wrote, we did not find particularly strong evidence that one scoring system was better than the other. I think as long as you can define severity of pneumonia with a tool that is easily accessible, you can rest assured you're dealing with a severe pneumonia. They're at a high risk of mortality, and this is a patient that should have corticosteroids started as soon as possible.
And that's probably a very practical way to look at it. PSI is the most cumbersome. Yes, it's a great predictor of mortality, but there's a lot of factors that go into it, as opposed to Smart Cop, Curb 65, which is probably our most simple. So you have severe pneumonia, recommending to start steroids sooner, within the first 24 hours, to give the patient best chance of survival, and a lot of other important factors like intubation, hospital length of stay. So what are some future studies that you can foresee being done on this topic?
I think that the question of the CRP level at which we define moderate disease or severe disease still needs to be answered. For those of us who practice critical care, as inflammation goes haywire and you go into cytokine storm or HLH, where is that transition or danger zone? We don't know. We can all recognize when it's already happened, but not when we're at risk. So that would be an interesting one. Another one would be to say, how much immunomodulation do we need? When is it safe to start tapering the steroids? And as an interesting side note, we do have some early data to suggest that different genders respond to steroids at a different rate. Females seem to respond much better. And the question whether they need less steroids is still open. Men seem to have more of the side effects. Women get more of the benefit. It's unfair, but that's how it is. Perhaps the other question would be, can we use other markers of inflammation? How about ferritin? We got really comfortable using that during COVID. There is some data for severe pneumonia, but in the trials that we've discussed today, they've not addressed ferritin. So that would be interesting. And at least borrowing from the data of ARDS, certainly IL-6 has been used as a marker of disease severity. It seems to me like it wouldn't be as readily available, more expensive, but where it could perhaps dovetail is to the question of how much immunomodulation do we need, and what would we do if a patient was not responding to steroids and they needed more help? Should they have more support with different medications? All of those questions still need to be answered for sure.
This was a great discussion. So as a quick summary, current literature supports the use of corticosteroids in severe community-acquired pneumonia. The best data we have is on hydrocortisone. We talked about the dose and when to taper. The severity of pneumonia, of course, we're using this in severe pneumonia. Sounds like PSI would be our best. However, it is the most cumbersome. So my recommendation would be to use something, whether it's Curb 65, Smart Cop, any of those validated tools that you see on MD Calc or one of these other medical apps, but use one of them to define severity of pneumonia. start steroids early. Don't wait till the patient hits the ICU. The timing is so important. Start it early. Use one of these validated tools. Hydrocortisone gives us at least the best data right now. Could you use other steroids? Probably. But right now, hydrocortisone looks like it has the best evidence. Be very cautious of side effects. These are important. Hyperglycemia, which we want to control blood sugars in the ICU between 140 to 180. That could change a little bit, but delirium is also a possibility due to steroids. And the last side effect, which we didn't see in these studies, would be GI bleeding. It's always a concern, but we didn't see it being a major side effect at all compared to placebo. Alex, just wrap it up. What are your closing thoughts on this?
I think you summed it up pretty good. For those of you that cannot wait to read 20 years of data to get to your own conclusions, we did a table where we summarized all the trials with the arguments for and against steroid use from 2015 onward. We did include even the meta-analysis that included Cape Cod from 2025, and you can find that at SCCM or the Cleveland Clinic Journal of Medicine.
Alex, we'll include your article in our show notes as well, so they'll have access to it to read it. It's a very nice, succinct summary of, as you said, maybe 20 plus years of research in that topic. Thank you, Dr. Chapa. I think this was a wonderful episode, really summarizing a lot of the data that's out there on corticosteroids with severe community-acquired pneumonia. Thank you, listeners, and we'll see you next time. And thank you for listening to Rebel EM.